Greeting from eMedinexus and IGCP Group. I'm Dr. K.K. Agarwal, its editor-in-chief. Welcome to our show, Chat with Dr. K.K. Today's discussion will be on an uncommon, still common disease. I say uncommon because uncommonly diagnosed, and common because now it is being increasingly being diagnosed in the country. And the disease is celiac disease. To discuss with me, I have two experts. Dr. Vineet Ahuja, who is the professor of Department of Gastroenterology and Human Nutrition at Delhi-based All India Institute of Medical Sciences. And with me is Dr. Vijay Yajnik, who is the director, Crohn's and Colitis Center, Mass General Hospital, Harvard Medical School, Boston, US. Welcome to our show. So, Vijay, how common is celiac in US?
So, celiac is a very common disease because, it's 1% of the American population has it. But if you take Scandinavia and other European countries, the number could be as high as 2%. So, as almost 1 in 100%, 1 in 100 patients we see with symptoms have celiac disease.
And what about in India?
India also, it seems to be fairly common. My colleague in the department, Dr. Govind Makharia, recently did a study whereby he looked at the community and found out roughly about same figures, 1 in 100. In fact, who had celiac disease, so serology was positive, celiac serology was positive in these patients. And finally, there was, I think, around 0.7 or 0.8% were diagnosed to have real celiac disease. And they also did a study along with CMC Vellore with Dr. B.S. Ramakrishna there, where they found the celiac disease was much less prevalent. And they did a study, Dr. Makhari also did a study with Dr. Goswami in Guwahati, where they found that it was not as common as Delhi, but definitely more common than South India. But in Delhi, and another study has been done by Dr. Ajit Sood from Ludhiana, and all these studies show that at least in North India, the predominantly eating area, the prevalence is as common as the people in US. So 1%.
So if I take that prevalence is 1%, and if I go back to my community medicine teaching and the preventive of social medicine, statistical teaching, it was clearly told to us at an MBBS level that any disease which has a prevalence of more than 1% should be included in your routine screening. So should I include celiac disease in the city like Delhi as a part of my comprehensive health checkup exam?
So my view on this is, I would say simple answer is no, because nobody is born with this disease. It's an acquired disease and it can happen early in childhood or even as late as in your 60s and 70s.
What do you mean by acquired disease?
Well, to a child that is born, so there are two types of conditions that one needs to distinguish. One is chronic inflammatory, which is my expertise is in Crohn's disease and ulcerative colitis. These are not autoimmune diseases. These are chronic inflammatory diseases because there is no presence of an autoantibody to an antigen that is a part of our tissue. So lupus has a double-stranded DNA positivity. Celiac disease is along the lines of an autoimmunity because there is a antibody in us. The patients have this antibody that's reacting to a protein that's on the epithelium of the small intestine. And that's why it is so distinct. And like with, rheumatoid arthritis and other autoimmune diseases, there's a spectrum. Some people develop it very early, some people develop it late. So unless you have symptoms that are suggestive of celiac disease, we do not routinely recommend it. The only caveat is if you have celiac disease, we are currently in the United States recommending family members to be tested because they may be having the antibody positive, but the symptoms have not come. And this way they can prepare and plan and do lifestyle and dietary.
So in which patient should I screen?
I think the patient that has unexplained diarrhea is one. There are many different manifestations. We have to go through a list. Another one is unexpected iron deficiency, unexpected liver and pancreatic enzyme abnormalities. There are some skin disorders that also often link to the gut, and they have celiac disease. And there's a type of dermatitis we call dermatitis.
So no, see again, let me come back. In India, hemoglobin is low in everybody. The average hemoglobin in a female you will get 8 to 10. No, I'm coming. So this is that criteria cannot be used. That criteria cannot be used. Diarrhea, yes, 4 weeks diarrhea. I should rule out a celiac disease. And the third thing you told was.
There are some signs of
So SGOT, SGPT, we have 37% metabolic syndrome, and out of them, half of them will have some SGOT, SGPT elevation. So So therefore, I need to really decide a criteria for India, which may be different from the US.
Correct. I think maybe we should include Dr. Ahuja in this discussion.
Yes.
Yeah, I think I would go with him totally. That even in India, I don't think that you need a general mass screening. But yes, there are certain known, well-described clinical scenarios where celiac disease may exist or coexist. So such situations you should investigate. First is obviously chronic diarrhea, but celiac disease at times can present
Chronic small intestinal diarrhea,
suspected. You should do a celiac
Celiac.
serology. But at times, celiac can present without diarrhea, may present just with anemia, iron deficiency anemia. So you would like to investigate all cases of iron deficiency anemia where no other obvious causes. Let's say a patient has come with hookworm infestation and anemia. There you don't need to
So all patients, all women or men or women, if they have unexplained, there's, suppose you say, what is the source of iron deficiency in me? I don't know. Rule out celiac. Okay.
investigate for celiac. Patient has unexplained transaminitis, rise in AST/ALT. Not a patient is hepatitis B positive and AST/ALT. A patient.
How do I differentiate it with NASH or with fatty liver?
So you cannot differentiate it if unless until you do a serology. If the serology is negative, the liver is fatty, all other.
And when I say raise SGOT, SGPT or AST/ALT, how much? More than double or just
More than.
more than double?
More than the upper limit of normal.
So even if I have, say, around what level? Because there is a
There you have to have two readings. Spread at least minimum interval between the two readings should be 4 weeks, preferably 3 months. So if you have done a LFT today, if it is more than 1 to 2 times the upper limit of normal, and that normal also keeps on changing, but let's keep it simple. That if it is there, and you
can there be a number, cut-off number? Because some people says 25, some people says 40.
not being defined. The lab, let's say a lab has a number of upper limit of 40, but today we are talking about that probably the Indian normal value is around 20.
25. Huh?
You would like to screen anything above 25. So let's not go into that kind of fine print at a primary level state. So if a patient has transaminitis, which may be 1 or 2 times above normal, upper limit of normal, and you repeat the liver function test after 4 weeks or 6 weeks, and you find a similar kind of figure, right? Then you know that the patient is transaminitis. You work up the patient, and the commonest thing you would like to do is rule out alcohol, rule out hepatitis B, rule out hepatitis C virus. Then you would go for autoimmune liver diseases. You will do an ultrasound, and if all these tests are negative, then you can subsequently look at lipid profile, thyroid profile, and then you will do a celiac test, celiac serology. So that is one scenario we can do. Patients who have, let us say, infertility, women with infertility problems, their celiac is again as a part of the workup. In diabetes, a celiac has a very high association. There it is a part of workup. As Dr. Yajnik told you, the first degree relatives, there's around 10% of first degree relatives, celiac is a very important part of workup. Sometimes in cases of neurological disorders, cerebral ataxia and all, celiac has a very high association. So there you would like to investigate. So that way these are scenarios which have been well described where you would like to investigate. Most common scenarios remain diarrhea or iron deficiency anemia or diabetes mellitus or first degree relatives, I would say.
Okay, when I want to do the test, say before that, what is the exact pathophysiology? How is it related to gluten?
So gluten. So when we think of wheat, we think it's carbohydrate. So there's no protein in wheat, but there is a very small percentage of protein in wheat, and this protein is very hard to digest. It has a lot of charged amino acids, and when this protein folding gets disrupted and transported across the membrane, it creates an immune activation. And immune activation leads to B cell response, which leads to a plasma cell response and expansion of TTG, IgA positive antibodies. And when celiac disease is untreated, it's not just the diarrhea, the risk is intestinal lymphoma, which is always fatal. That is why we are very, very specific in saying we have to investigate who has it, because we can prevent not only morbidity, but also mortality.
So how is it linked with gluten now?
This is that it is linked with gluten. The gluten is the protein which is there, that leads to a reaction, autoimmune reaction. So as a result, that leads to a lot of inflammation out there and destruction.
So these are the patients who need to be on a gluten-free diet.
Yes. So let me just specify. We say TTG. TTG is a brush border. It's an enzyme. So when that gets disrupted, the villus height gets disrupted, and that's called sprue. Sprue basically means that there is an intestinal cell. The cells are present. There's no ulcer, but the cell shape and differentiation is completely gone. The cell is flat and like ball, like my head.
Okay, when I do for a serology, we talk about TTG IgA test. What exactly is this test? What exactly is this test? Serology. So I send a blood.
It's an IgA, you're measuring IgA levels to against tissue transglutaminase, which is a ubiquitous enzyme in the epithelial.
So positive test means what? Negative means what? Can it be false positive, false negative?
It can be falsely positive. First of all, is positive cell. Let's say the upper limit of normal is, let's say, 20, right? Most labs are, it depends from kit to kit. So it is just above the upper limit of normal. It's a positive. Suppose it is 10 times the upper limit of normal, then it suggests strongly, very strongly suggests that it is celiac. But again, there it is not diagnostic at the moment. You need to, because there can be false positives. So you need to do an endoscopy and do a duodenal biopsy. And in duodenal biopsy, if you find that there is complete villus atrophy or there is degrees of villus atrophy, then that would confirm the diagnosis of celiac.
So all cases.
One serology you cannot, although in children, recent guidelines which have come up 2 years back suggest that along with IgA TTG, you can also do a IG, and along with that, you can do an anti-endomycin antibody. If both of the serologies are positive, then you may avoid a duodenal biopsy, particularly it's difficult in children. Third thing, always some patients may have IgA levels deficient, serum IgA levels deficient. So there may be a falsely negative TTG. Once you're talking of falsely positive, so if you're doing an IgA TTG, always it's preferable to either confirm it with a duodenal biopsy or at the same time measure serum IgA levels also. Because if serum IgA levels are normal, IgA TTG is negative, then you do not need to proceed further. So then you know that the
But to simplify, the first test is serum TTG IgA. Along with that, a duodenal biopsy.
Is it possible, if you can do it, then do a serum IgA level also?
Is it reliable in India, serum IgA levels? All labs are doing it and it is reliable. So you do for a serum TTG IgA, serum IgA level, and then to be confirmed by a duodenal biopsy. Okay, now a patient has a.
Very important is that sometimes just on the basis of a serology, somebody is diagnosed as celiac disease and put on a gluten-free diet. Now that causes a whole range of change in the lifestyle for that patient, and most of the
Therefore, diagnosis has to be 100% confirmed. Okay, now I've referred it to a GI. He has confirmed it to be a celiac disease. Okay, now he comes back to me as a family physician. What do I do? A, advise him on a gluten-free diet. What does it mean?
There's a whole list: wheat, barley, rice. Rye is out.
Zero diet.
Zero diet. Even 20 milligrams or 50 milligrams can cause some damage. So zero. So you have a whole list of food material which may have gluten. That may range from some kinds of ice creams to any other thing which you're not even aware of. You're not talking of simple roti, we're not talking of cake, we're not talking of...
But I need to give an answer to a roti. So therefore, besan is zero gluten.
My recommendation is zero gluten.
No, therefore I'm saying I have to give an alternative for a roti. So I says from wheat to go to besan, makkah, and rice. So I need to give a solution to the person, otherwise he will not listen to me.
A simple solution is absolute abstinence and then switch to besan and rice containing flour.
So he should go back to a absolutely gluten-free diet. And apart from that, does he need any other treatment?
Well, I tend to check.
Uncomplicated.
I tend to check the TTG IgA again after a few months of being gluten-free. If the level of the antibody or the titer of the antibody goes down, you've confirmed with the patient that this is truly celiac disease. And this will also reiterate and also make the patient really believe that this is the right diagnosis, because, it's a very major change of life to eat no wheat. I mean, we all love our parathas in the morning. And so I think it's important to be very accurate in this. So I repeat celiac testing months later and then show it.
Before I go further, when I talk to my Ayurvedic friends and I start reading Vedic descriptions, there is a mention of a condition called Anna Dosh. It's clearly described in Vedic literature, a disease called Anna Dosh, which may have two meanings. One of the meaning can be that they were referring to celiac disease. Anna basically there means gehu. In Ayurveda, Anna means gehu. Gehu is the staple diet for Anna. Dosh means a disorder. So there can be two interpretations of that. Either they are talking about celiac disease, or they are talking about heavy carbohydrate diet leading to insulinemia, hyperinsulinemia, metabolic syndrome, diabetes, pot belly obesity, central obesity, and heart disease. These two things are, and this term is described. So that means Rishi Muni at that time knew that either we have a we have celiac disease in the country, or we have a hypersensitivity to wheat leading to insulin
I
resistance.
think this has also been described in the Western world. Hippocrates described a patient, a child that had intolerance to wheat. So unlike Crohn's disease and ulcerative colitis, which you think are relatively new disease, I think celiac has always been there. But over the course of our human evolution, we solved famine and poverty. Wheat was a type of a grain that grew across the globe and with very quick, rapid expansion. So I'm thinking back in the day, people were taking all kinds of different, grains, not just wheat. In the more modern world, we've become a pure wheat diet. Our microbiome has also potentially changed. So taking together the changes in the microbiome and the extreme use of wheat, I think we're seeing the increase in the prevalence of celiac disease.
You said that celiac is an acquired disease. It's not present congenitally. And if that's so, then in the families, how do I suppose? How do I pick up? How do I prevent it being acquired in my family members?
And this is a beautiful question, and I don't think any of us know really the answer.
There. Can I come back to that? All my family members who are, even if today they are TTG, IgA negative, should they be restricting their gluten diet once in a week or twice in a week?
We do not recommend that. If you're at the time of testing, if you're TTG, IgA negative, we do not. I think being gluten free is a big burden. It's a financial burden. It's not just it's not available. Everything that's gluten free is at a much higher cost. In the United States, the U.S. government gave college students tax-free benefits because every time they go for a gluten-free muffin, it costs 3 times the cost of a regular muffin. So we're putting a lot of pressure on these patients financially as well. So what we do is, if you're negative, we say you can repeat a testing when if you have symptoms, but that one-time negative is considered negative.
Is in the acquired thing, one thing you can say is along with that, there's a predisposition is there. That is, we have HLA type. So there's HLA DQ2 and DQ8. They are all present in 98%, you can say, of the celiac patients.
And this test now is available.
This is available.
Okay.
Right. So if you are in the family, this always, this test has not to be done anywhere. But where you're suspecting celiac, so you want to find, is there a predisposition or not? The patient may have serology which is negative, but he is a first degree relative. Actually, DQ2, DQ8 is positive. So you know, yes, okay, there's a potential celiac. There's a chance.
So if a person is HLA DQ2 and 8 positive and TTG negative,
20% of normal population is also HLA DQ2, DQ8 positive, whereas 98% or 99% of celiac population is HLA DQ2, DQ8 positive. Right? So if HLA DQ2, DQ8 is positive, does not definitely say that you have a 100% chance of being predisposed to celiac disease. However, if you have first degree relative also with celiac disease, then obviously your chances are increasing. Now the problem is that can you do something to prevent it further? Right now, I don't think you can do anything to prevent it.
so therefore, if somebody is HLA DQ2 or DQ8 positive, TTG IgA negative, nothing to be done.
Nothing to be done.
But you know that this patient has provided there's a family history also which is there. So then this patient probably would have it.
But I would definitely like to add one thing from my cardiology practice, that if you take carb every day, you will end up into hyperinsulinemia, metabolic syndrome, fatty liver. I did examine 100 women doing fast once in a week and 100 not doing. The chances of developing insulin resistance are much higher those who are not doing fast. So traditionally, our Rishi Muni's fast of not eating carbs once in a week, not eating once in a month extra on the day of Ekadashi, and 18 days extra in Navratras. You don't eat gehu. Gehu is something which you don't eat. You don't offer gehu to God. You don't offer gehu to God. So therefore, traditionally, Rishi Munis have been telling us that eating wheat every day is injurious to your health, whether by celiac or whether by insulin resistance is a different issue. So therefore, for those people who are HLA DQ2 and 8 positive, they specifically should listen to me and avoid eating wheat at least once in a week. At least once in a week as a fast. They should. I said my recommendation. I'm not saying recommendation from the GI experts. Because I tell it to everybody. I say everybody should not take wheat once in a week. That's my general recommendation, and which I insist.
I think it's a very metabolic syndrome rising. I think, and then we don't know the endocrine response of starvation. It may have a lot of benefits, global benefits, not just in heart, GI tract, microbiome, etc. So I think it's important. I think I appreciate that point.
So what what we have heard and listened today and learned today is that any chronic diarrhea, small intestinal in nature, if you have an unexplained anemia, iron deficiency anemia, you can't find any cause. And if you find any unexplained infertility, and in all such cases, you should be able to, you always keep in mind that am I dealing with a celiac disease? Celiac disease is present in 1% of the society, very high number, therefore high degree of suspicion is required. And celiac disease can easily be managed with a gluten-free diet. And therefore, it is very important to diagnose a case, and equally important to diagnose it, because once you are going to ask him to not to eat wheat forever, you really need to be very clear in your diagnosis. It's not a congenital disease, it's an acquired disease. The family members of celiac disease should be investigated. Investigation of choice is very simple, blood test. We go for a serum TTG IgA levels and also a serum IgA level simultaneously, because if the serum IgA levels are low, then the results can be fallacious of TTG IgA. And once the diagnosis is suspected with TTG IgA, send him to a gastroenterologist, ask him whether he would like to do a duodenal biopsy to confirm and for a follow-up. And follow this patient with a gluten-free diet and look for complications. And let's thank both Vineet and Vijay to be here with us in this show. And I'm sure that celiac disease is, from today onwards, you should be able to diagnose celiac disease in your practice. We'll come back with one more show. Till that, goodbye. Thank you.